Hello, welcome back to my channel. Today we are going to discuss about a case report. So today's case report is chronic kidney disease with anemia, resistant hypertension, uremic encephalopathy and hypocalcemia. It's regarding an elderly female. She complained of generalized weakness, fatigue, anorexia, and she had multiple episodes of vomiting, and she was drowsy when she first arrived to us in the emergency. She was a known case of hypertension, and she was not on regular medications, and she was first diagnosed with hypertension 10 years back. On examination, her BP was going through the roof. Her systolic blood pressure was 200 mmHg and her diastolic blood pressure was 100 mmHg. Her pulse rate was high. She was tachycardic. Her temperature was not raised. Her saturation was 89-90 in room air, and she had severe pallor, and her tongue was also dry. The four main things that we are going to discuss regarding this case are: the patient had severe anemia, and there was resistant hypertension and hypocalcemia, uremic encephalopathy. We can say this, that the patient had resistant hypertension because she was on 3 or 4 drugs which included a diuretic as well, but her pressure was not controlled. Okay, so we will discuss about what are the contributing factors which lead to resistant hypertension in a known case of chronic kidney disease grade 5. First is volume overload. So what are the factors contributing to volume overload? First thing is GFR is reduced, that will lead to salt and water retention. Second is non-adherence to fluid restriction. Third is inadequate diuretic therapy or second point which results in resistant hypertension, we can say that is activation of RAS, renin-angiotensin aldosterone system. So it causes vasoconstriction via angiotensin 2, it causes salt and water retention via aldosterone, and it causes vascular remodeling and stiffness. Third point which contributes to resistant hypertension is activation of sympathetic nervous system. It causes vasoconstriction, tachycardia and increased beat. Fourth point contributing to resistant hypertension is secondary hyperparathyroidism and hypocalcemia. As CKD progresses from grade 1 to grade 5, we can see that phosphatemia increases, that is level of phosphate in the blood increases because kidneys are unable to excrete the phosphate. Especially in grade 3 CKD, we can see that osteocytes will produce FGF23, that is fibroblast growth factor 23. FGF23 is a phosphaturic hormone. It increases the excretion of phosphate up to a certain level because it inhibits the sodium phosphate receptor which is present on proximal convoluted tubule through clotho-receptor. It inhibits 1-alpha hydroxylase which causes calcitriol levels to drop and which causes hypocalcemia. FGF23 also promotes LVA. When it causes reduction in calcitriol levels, so we can see that we have hypocalcemia, and because there is reduced intestinal absorption of calcium which causes PTH to be activated. So parathormone gets activated and we have secondary hyperparathyroidism. What is uremic encephalopathy? So uremic encephalopathy is a reversible neuropsychiatric syndrome that develops due to accumulation of neurotoxic metabolites. So we will discuss about what are the factors which causes uremic encephalopathy in a patient with chronic kidney disease. So first thing is there is accumulation of uremic toxins, and there is disruption of blood-brain barrier, and there is increase in inhibitory neurotransmitters and decrease in excitatory neurotransmitters. There is also metabolic derangements, and if the patient is experiencing untreated uremic encephalopathy for a very long time, then there is irreversible damage to the brain. How hypocalcemia occurs in a patient with chronic kidney disease? We have discussed a little bit of secondary hyperparathyroidism and how hypocalcemia occurs. Still we are going to revise it a little bit. When do you call a patient is experiencing hypocalcemia? When the total serum calcium is less than 8.5 mg per dl or the ionized calcium is less than 4.5 mg per dl, we say that the patient is having hypocalcemia. Usually it is seen in grade 3 to grade 5 of CKD. It is usually due to calcium, phosphate, vitamin D, parathormone axis. we have seen that when the CKD is progressing from grade 1 to grade 5, usually in grade 3 we can see that there is activation of osteocytes. Osteocytes will produce FGF23. FGF23, that is fibroblast growth factor, it inhibits 1-alpha hydroxylase and causes calcitriol reduction. Reduced calcitriol causes reduced absorption of calcium from intestines, which causes hypocalcemia. Hypocalcemia triggers parathormone to get active. Hypocalcemia stimulates parathyroid hormone, and parathyroid hormone causes secondary hyperparathyroidism. As the disease progresses, there is also reduced expression of clothioreceptors. So we are going to discuss about chronic anemia in a patient with CKD. This patient specifically presented to us with a hemoglobin of 5.3 gram per dl. We transfused 5 units PRBC, and post transfusion her hemoglobin was 9.8 gram per dl. Okay, so let's discuss about what are the factors contributing to chronic anemia in a chronic kidney disease patient. So first thing is there is reduced erythropoietin production. Second thing is there is hemodilution due to volume overload. There can be iron deficiency, folate deficiency, vitamin B12 deficiency. There is chronic inflammation, and there can be aluminum toxicity. It used to happen in old dialysis. Also hyperparathyroidism. First thing what we treated in this patient was anemia, and there was resistant hypertension and uremic encephalopathy and hypocalcemia. So for anemia, we transfused 5 units of PRBC, and we also made sure that there was no volume overload and there was no citrate toxicity, and we made sure of that. For uremic encephalopathy, the patient was put through HD, renal replacement therapy, and resistant hypertension was also managed very conservatively, and hypocalcemia was also managed. Because patient was having resistant hypertension, patient was having uremic encephalopathy, patient was having hypocalcemia, patient was having seizures, and we just couldn't figure out what was the reason for the seizures, because everything can be a reason for the seizures that was happening. And we also couldn't move the patient, and we also couldn't do MRI because the patient was not hemodynamically stable. And so nephrologist opinion was taken, general physician regularly visited the patient, neurologist opinion was taken, everything opinion was summarized. So conservative management was started and relevant investigations were done. Patient responded well to the treatment, and patient was being discharged in hemodynamically stable condition. Thank you.